that's why the next thing is to decide whether below a particular lead, whether you have a total myocardial necrosis or some amount of healthy myocardium is there, whether the myocardial area is more or the necrosed myocardium is more. Having decided there is necrosis, below that particular lead there may be total necrosis, there may be small myocardium which is healthy, or total myocardial infarct area may be little. So you can see this ECG, you can see that V1 to V3, V1 to V3, there is no R wave at all, isn't it? Normally what will happen, V1 to V3, the R wave should progress from V to V3, the R wave should keep on increasing. So here absolutely there is no wave, so it's a pathological Q wave. In what territory now? What territory? LAD. So depending upon the depth of the Q wave and the succeeding R, you can decide whether below that particular electrode I have a total necrosis or healthy myocardium is more or infarct myocardium is more. For example, let us see here. Here my infarct myocardium is more and I have a small healthy myocardium. So below this lead I will have a Q wave which is deeper than the R wave. Because my healthy myocardium is small, my R wave is small, my infarct area is big, my Q wave is big. Whereas here I have a small area of infarct but my healthy myocardium is more. So here, although I have a pathological Q wave, the Q wave depth is less than the R wave amplitude. So whenever the R wave is tall and the Q wave is small, then you know below that electrode I have small infarct area and a predominant healthy myocardium. So Q wave is deep, more of infarct area, less of healthy myocardium. When the Q wave is small, more of healthy myocardium and less of infarct area. Whereas there is no healthy myocardium at all. From the epicardium to endocardium, the whole thing is infarcted. I will not have any R wave at all. Below that electrode, I will have only Q wave, only the Q wave without any R wave. So look at this CCG here. V1 to V3, V1 to V2, V2, I don't have any R wave, isn't it? So what I imagine, below V2, I have totally dead myocardium. Whereas V3, I have a deep Q and a small R. So below V3, what I have? More of infarct area, less of healthy myocardium. Whereas see V4, my R wave is big and the Q wave has become smaller. So below V4, I have more of healthy myocardium, less of infarct myocardium. So total QS, deep Q wave, small R wave, small Q wave, big R wave. So not only diagnose myocardial infarction, below that particular electrode, you know, whatever. So for example, let us say V1 to V6, I have no R wave at all, only the Q wave. Let us imagine one ECG is showing V1 to V6, only the Q wave. What does it mean? Throughout our myocardium, I do not have a healthy myocardium, so this patient has got a significant LV dysfunction. The whole of the left ventricular myocardium is dead, no healthy myocardium. Whereas infarct like this, what I infer? Only a small area I have infarct, majority of area is still healthy. So this fellow will have a good prognosis. Whereas a fellow who has got V1 to V6 with no R wave, V1 to V6, everything is Q wave, this fellow will have a bad prognosis. So not only diagnose infarction, you diagnose how much of the myocardium is involved in this infarction process. The last thing before we adjourn for tea is a posterior myocardial infarction. So it's easy to diagnose all myocardial infarctions, isn't it? But I told you the posterior myocardial infarction can be diagnosed only by the reciprocal changes we are happening in the anterowall infarction. So when the posterior wall infarction is there, if we are able to record an ECG placing an electrode on the posterior surface, what will it show? It will show a pathological Q wave, isn't it? It will show a pathological Q wave and inverted T wave because of the ischemia. So I am not doing that. So what I am trying to do is from V1 and V2, I am trying to interpret what is happening in the posterior wall. So when the posterior wall, this is exactly the opposite things is going to happen in my anterowall. So the Q wave will become the R wave, inverted T wave will become the upright R wave. Remember, so the posterior wall is diagnosed especially in the presence of inferior wall infarction, the presence of tall R wave in V1. So in all inferior wall infarctions, you must immediately look at, everybody will be looking at the inferior leads to diagnose inferior wall infarction. You must do what? You must look what others will miss. Others will miss posterior wall infarction. You must immediately go and look at the V1. If the V1 shows a tall R wave in the presence of inferior wall infarction, what is you infer? In addition to inferior wall infarction, you have posterior wall infarction because this R wave in V1 represent the Q wave in the posterior region. Right? So that is the importance of looking beyond what is obvious. Like in this ECG, you can see what is the diagnosis here. What is a single sentence diagnosis here? Chronic occlusion of right coronary artery. So it's a chronic total occlusion of RCA because you have a pathological Q wave. You have a pathological Q wave. What I wanted to see, tall R wave. You immediately look at V1. Tall R wave with the upright T wave. So what does it mean? Posterior wall infarction. Is there any other conditions you know which can produce tall R wave in V1? Right ventricular hypertrophy, right bundle branch block. So what are the three reasons of tall R wave in V1? Right ventricular hypertrophy, right bundle branch block, and how will you differentiate between these three? Why can't be right ventricular hypertrophy here? You tell me. Excellent. So why it's not right ventricular hypertrophy? Tall R wave in V1 more than 7 millimeters. Why not right ventricular hypertrophy? What is your axis? It is actually left axis, going towards the left, isn't it? So it cannot be a right ventricular hypertrophy. Why it is not right bundle branch block? QRS widening is not there, right? QRS widening is not there. That's why it is not right bundle branch block. It is associated with inferior wall infarction. So what is the diagnosis? Posterior wall infarction. So if a tall R wave associated with right axis deviation, right ventricular hypertrophy, tall R wave is associated with the white QRS right bundle branch block, tall R wave associated with inferior wall infarction, posterior wall infarction. These are three differential diagnoses for a tall R wave in V1. Is that clear? So it's very logical. ECG is so easy. Only thing is you have to keep on applying the logical things and put it in appropriate place. So there's a classical posterior wall infarction. Most often the T wave will be upright. Many times you have seen the T wave in V1 is down, but here the inverted T wave in posterior wall will be seen as an upright T wave in V1. So always in inferior wall infarction, look at the posterior wall. So this is the summary slide. So in coronary heart disease, we have three manifestations of ischemia, injury and infarction. Ischemia is shown by the T wave change. The ischemia can be subepicardial ischemia, which will produce a T wave inversion. Subendocardial ischemia will produce a tall T wave. For T wave inversion, the differential diagnosis is secondary STT change. For the tall T wave, the differential diagnosis is hyperkalemia. When there is an injury, it can be, you have to look at the ST segment. It can be a subepicardial injury, which will produce an ST segment elevation. Subendocardial injury, which will produce ST segment depression. Subepicardial injury is acute total occlusion, red thrombus, myocardium is dying, you must do a thrombolytic immediately. Whereas subendocardial injury, critical occlusion, white thrombus, viable myocardium is still present, you must give heparin and aspirin and do not thrombolyze these patients. Whereas infarction, it affects the QRS complex, produces a pathological Q wave, differentiating between the physiological and pathological Q wave, and it is irreversible. As I told you, by energetically treating ischemia and injury, you should not see infarction in your patient's ECG. And how to diagnose a posterior wall infarction? The opposite of Q wave in V1 and V2 in the presence of inferior wall infarction, and the three differential diagnoses for tall R wave in V1 completes this lecture. And of course, ischemia, it can be acute or chronic. If it is a subendocardial ischemia, tall T waves still could be an acute coronary syndrome. ST segment is always acute and infarction is always chronic. Right? Take your pads and respond. RCA perfusion, right coronary artery perfusion is through inferior leads, superior leads, V2 to V4, V5, V6. I will not say 100 means 96. So inferior leads. Right. Injury shown by, yes. ST segment. Symmetrical T wave inversion, primary ischemia, secondary due to bundle block ventricular hypertrophy, tertiary change. What is tertiary changes? Which condition produces tertiary ST changes? There is no tertiary ST changes. Subendocardial injury produces ST elevation, ST depression. Subendocardial injury. ST depression. Subepicardial injury, acute total occlusion, acute critical occlusion, chronic total occlusion. Subepicardial injury. Yes. So acute critical, 16% acute critical occlusion. Subepicardial injury is ST elevation. ST elevation is always acute total occlusion due to red thrombus. Please remember, acute critical occlusion is by the subepicardial injury. So acute total occlusion always produces subepicardial injury, which produces ST segment elevation. Acute total occlusion. Okay, the ECGs we see at the end of this CAD2 chapter. Madam?
We'll now break for tea. We'll be back by 11:05. Before we break, I'd like to make an announcement that the DVDs of the ECG, the current workshop, the full DVD is available for sale by Dr. Chennappan. It's available at the registration counter. So please do get your copy. There are only 40 copies. So